sixth and final episode of our vodcast series on increasing healthcare professional understanding and awareness of shingles. Over the past 5 episodes, we discussed that healthcare professionals should recognize the burden of shingles or herpes zoster, especially in patients who are immunocompromised and populations with comorbidities. Other discussions addressed how to prioritize vaccination, understand its efficacy and safety, and collaborate across the care team to promote uptake while addressing barriers, disparities, and inequities. Affecting approximately 1 in 3 adults over their lifetime is particularly impactful in older adults and those who with immunocompromising conditions. While many may think of shingles as a localized skin condition, it is far more complex, associated with severe neuropathic pain, long-term complications, and meaningful impacts on quality of life. Despite advances in prevention and treatment, gaps remain in awareness, risk identification, and care coordination. In this episode, we'll explore the evolving burden of shingles, from epidemiology and clinical impact to risk factors and complications, while also looking ahead to how healthcare systems can shift toward more proactive, prevention-focused strategies to reduce its impact. As we get started, I want to mention that this educational activity is supported by an independent medical education grant from GSK. Recommendations and opinions presented may not represent the official positions of the American Heart Association and the American Stroke Association. The materials are for educational purposes only, do not endorse any product or device, and do not constitute an endorsement or instruction by the associations. I'm Karen Larmer. I'm a longtime volunteer for the American Heart Association. My research focuses on heart failure and medical device technology, and joining me is a distinguished multidisciplinary panel.
Hi, I'm Andrew Huang. I'm an associate professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences and a clinical research pharmacist at the Brigham and Women's Hospital.
Hi, everyone. I'm Anthony Vieira. I'm a practicing family physician and chair of family medicine and community health at Duke University. Good to see you.
Thank you so much for joining us. The first part of our discussion is going to focus on shifting from reactive to preventive care. And I will start by asking Dr. Vieira, how do you see the management of shingles evolving from a reactive treatment-based model to a more proactive prevention-first approach in the next 5 to 10 years?
Yeah, that's a great question. As you know, today shingles is managed reactively. The patient presents with the classic syndrome and the rash, and then is given antivirals and pain control. Over the next decade, shingles management will transition from an episodic treatment paradigm to a lifelong immune risk management strategy, where vaccination, predictive analytics, and immune monitoring are used to prevent reactivation before it occurs. We'll move from an age-based vaccination, for example, greater than or equal to 50 years or immunocompromised, to earlier vaccination based on risk, not just age. We'll also integrate this care into healthy aging and neuroprotection. Shingles prevention will increasingly align with goals of reducing post-herpetic neuralgia, functional decline, and downstream risks such as stroke and cognitive decline.
Very interesting. What do you think it would take to embed this shingles risk assessment into routine preventive care and these workflows across specialties?
Yeah, so embedding shingles risk assessment into routine preventive care across specialties will require elevating it from a guideline-based recommendation to a system-embedded clinical function that operates seamlessly across the care continuum. I believe this needs to be built on a validated, easy-to-interpret risk model that translates directly into action and is integrated into our electronic health records as both a passive background calculation as well as an active context-specific prompt at key clinical moments, such as patients' annual visits or someone coming in for initiation of immunosuppressive therapy. Together, primary care clinicians, specialists, and pharmacies are all supported by closed-loop interoperability that ensures vaccination orders, administration, and documentation flow effortlessly across settings. And sustaining this will depend on reframing shingles as a predictable and preventable manifestation of immune decline, thereby normalizing its assessment alongside other chronic risk calculations like we do for atherosclerotic cardiovascular disease, and reinforcing its role within broader healthy aging and immune resilience strategies.
Thank you. Now I'm going to pull back a little bit the view and get to the bigger picture even. So Dr. Huang, What role do you believe predictive analytics or population health tools play in identifying patients at highest risk before disease onset?
Yeah, great question. So from a pharmacist and informatics perspective, predictive analytics really gives us the opportunity to shift shingles prevention from reactive care to proactive identification. So we all know we already have access to a wide variety of key risk factors such as age, chronic conditions, and medication exposure. So by integrating these data points into population health tools, we can stratify patients and generate actionable lists, essentially identifying individuals who are both eligible and at elevated risk but remain unvaccinated. That allows us to focus outreach efforts where they'll have the greatest impact rather than relying on broad, less targeted approaches. At a systems level, these tools help anticipate future disease burden and complications, which is important as we think about the aging population and increasing immunosuppression. Ultimately, the goal is to embed predictive insights directly into clinical workflows so that when a patient is identified as high risk, that insight can translate into a real-time action.
Great. I'm going to turn this question back over to Dr. Vieira. We recognize more systemic and neuralgic complications of shingles, how should that change how clinicians think about the disease's severity?
Yeah, as the spectrum of systemic and neurologic complications associated with shingles becomes more fully appreciated, clinicians will need to fundamentally reframe the disease from a self-limited dermatologic condition with a nuisance rash to a multi-system inflammatory event with meaningful short and long-term health consequences. This includes not only well-recognized outcomes like postherpetic neuralgia, but also growing recognition of associations with stroke, myocardial infarction, functional decline, and possibly even cognitive impairment, which collectively elevates shingles into the category of conditions that can precipitate or signal broader physiologic vulnerability. As a result, severity should no longer be judged solely by the acuity or extent of the rash and pain, but by the disease's downstream risk impact, particularly in our older or immunologically fragile patients. This shift should drive a mental model change akin to how clinicians think about influenza or pneumonia. That is, not just as acute infections, but as events that can destabilize underlying systems, thereby strengthening the rationale for early antiviral treatment, aggressive symptom control, and most importantly, prioritization of prevention as a way to avert cascading complications rather than simply treating an isolated episode.
That's such an important perspective. Dr. Vieira, what opportunities exist to improve early detection, especially in patients with atypical or pre-rash symptoms?
Yeah, I really like this question. So improving early detection of shingles, particularly the atypical and pre-rash presentations, will depend less on any single diagnostic breakthrough and more on systematically codifying the recognition of the prodromal state, embedding that recognition into clinical workflows, and lowering the threshold for action in high-risk patients. In practice, this will mean shifting from a model that requires cutaneous confirmation, i.e., I see the rash, to one that is comfortable acting on probabilistic early disease signals, pain without a rash, for example. And these will all be supported by decision support, emerging diagnostics, and rapid follow-up pathways.
Thank you. Now, turning back to Dr. Huang, recognizing that we have more technological tools in our grasp than ever before, how can we better leverage our current EHR data, our medication lists, our comorbidity profiles to proactively identify high-risk patients?
Yeah, so I think the key challenge here is not the availability of data, but how effectively we can activate and connect the data that we already have. EHRs contain rich information, and medication lists can be particularly valuable. They often serve as an early and reliable signal of immunocompromised status. So one practical approach is building a medication-driven trigger into the EHR. So for example, when a biologic or chronic steroid is prescribed or dispensed, that can prompt an automatic check for shingles vaccination status. We can then layer in comorbidity profiles such as diabetes or chronic kidney disease, which can further elevate the risk and should reinforce the need for vaccination. Another opportunity is identifying missed opportunities. So we can use encounter and immunization data to flag patients who have been seen in the last year but remain unvaccinated, or those who initiated the vaccine but have not received the second dose. Of course, this all depends on the interoperability, so ensuring data flows between pharmacies, health systems, and immunization registries so that vaccination status is accurate and actionable wherever the patient presents.
That's fascinating, and so important. Now, Dr. Vieira, as a healthcare professionals, we recognize that the standard of care is always evolving. Do you think shingles vaccination will become a routine default preventive measure similar to flu or pneumococcal vaccines? And what barriers need to be addressed in order to get us there?
Yeah, I definitely think shingles vaccination is highly likely to become routine and a default preventive intervention over the next 10 years. But it will rely on transitioning from a clinician-driven recommendation to a system-driven expectation. And this can be supported by simplified eligibility frameworks, embedded decision support, shared cross-specialty ownership, pharmacy integrated delivery, and aligned incentives. The pivotal shift will be reframing shingles from a quality of life illness to a preventable marker of immune vulnerability with systemic consequences, thereby elevating its priority to the level required for consistent automatic adoption in our preventive care workflows.
And Dr. Wong, from your perspective, how might this emerging evidence, such as potential cardiovascular benefits, reshape how clinicians prioritize shingles vaccination?
Yeah, so I think emerging evidence has the potential to significantly broaden how we think about shingles vaccination. So traditionally, vaccination has always been primarily prioritized to prevent herpes zoster and its complications, but now we're seeing growing evidence suggesting much broader benefits. So, for example, recent studies evaluating the live attenuated zoster vaccine have shown associations with reduced cardiovascular events such as stroke, myocardial infarction, and heart failure. There's also emerging evidence suggesting a potential reduction in the risk of dementia among vaccinated individuals. But it's important to note that these studies are observational and were conducted with the live vaccine, but they do point toward an important concept that preventing shingles and its associated inflammatory and immune response may have downstream benefits on vascular and neurologic health. From a clinical prioritization standpoint, this could be especially meaningful for patients who have already have elevated cardiovascular risk. This allows the clinician to reframe that conversation with the patient from not just preventing that painful rash, but also potentially contributing to broader long-term health outcomes. That said, since the recombinant zoster vaccine has largely replaced the live vaccine in the United States, future studies evaluating whether these broader benefits also extend to the recombinant vaccine will be critical. And early data appear to be pretty promising.
Thank you. Now, shifting toward transforming our care delivery systems, I think we all recognize that a multidisciplinary approach is imperative in patient care. So, how do you see the roles of pharmacists, specialists, and primary care evolving in a more coordinated vaccination ecosystem?
Yeah, this is a very important question. And I can discuss this from a pharmacist perspective. So the role of pharmacists is really evolving toward being central drivers of vaccination delivery and follow through. We are in the unique position that we engage patients across multiple settings, from community pharmacies to specialty care, which really gives us both the visibility into the risk and the ability to act on it. In practical terms, pharmacists can help identify eligible patients through medication review, assess risk in real time, and administer vaccines at the point of care. But just as importantly, we can also play a role in ensuring completion of that two-dose shingles series, which remains a significant gap. We're also well positioned to bridge fragmentation in the system. When a provider recommends a vaccine, the pharmacists can help ensure that that recommendation is actually executed. So whether through direct administration, scheduling, or follow-up. And so as pharmacists become more integrated into population health strategies, we can also manage panels of at-risk patients by conducting outreach, tracking vaccine status, and closing care gaps.
Understanding this multidisciplinary approach and the tools that we have at hand, specifically the future of digital tools like automated reminders, EHR alerts, and any kind of AI in improving completion of the two-dose vaccine series. What do you see as the future of these?
So I think digital tools are going to be essential in improving completion of the two-dose vaccine series. So one of the biggest challenges is ensuring patients come back for that second dose. Automated reminders such as text messages or portal notifications can be very effective when they're timed appropriately within that 2 to 6 month window. At the same time, EHR-based clinical decision supports can help play a key role, but alerts really need to be well designed. So, for example, they need to be targeted, actionable, and integrated into the clinician's workflow, whether that's during a visit or prescribing high-risk medications. And then when we look ahead, AI can take this even further by helping us predict which patients may be less likely to complete the series and help tailor interventions accordingly. So, for example, some patients may respond well to automated reminders, while others may benefit more from a more direct outreach from a clinical staff. And then we also need to ensure that these tracking tools, such as dashboards, that allow these tracking tools need to be shared. So these dashboards that allow care teams to monitor who has received the first dose and who is overdue for that second dose. This not only makes it easier to actively intervene, but also helps improve coordination with the healthcare team. But overall, digital tools allow us to move from passive recommendations to actively managing vaccination, which is key to improving outcomes.
Yeah, that's great. I'd like to jump in here for a second, Andrew. That's a great overview of how digital tools can help us move from passive recommendations to more proactive vaccine management. And building on that, I've been thinking about the patient's perspective. Karen, as a nurse practitioner, in your view, what strategies will be most effective in shifting patient awareness from low urgency to recognizing shingles as a preventable, potentially high impact disease?
Well, thanks for that question. Often the reason patients, I think, dismiss shingles is a perception problem. And, we always talk about being with the patient where they are, the person, so identifying where they are in their understanding of things and their acceptance of a disease process or potential disease. So it's not so much an information problem a lot of times as it is a perception problem. Most patients, I think, believe they think of shingles still as a rash that's temporary and inconvenient. Probably not for those that have had it, but for those that haven't had it before. So our job as healthcare professionals is to reframe the threat and the window to prevent it. That's critical in terms of patients and how they actually feel about it. So I have a few tips I think that come to mind that work when I'm coaching and working with patients. I think first we want to lead with consequences, not the virus itself. I think it's fascinating for us to talk about the epidemiology and the virology, but I wouldn't recommend opening with that with patients. Open with what shingles does to a life. Post-herpetic neuralgia, or PHN, affects about 10 to 18% of shingles patients with nerve pain that lingers more than 90 days. We've all seen those patients, and it's really tough. After the rash, this can persist for years. Herpes zoster ophthalmicus affects about 10 to 25% of patients and can cause vision loss. PHN is associated with significantly decreased quality of life, with the most effective domains being sleep and mood, general activity. So patients need to know this isn't just a rash that goes away in a couple of weeks. For 1 in 10 patients, this becomes a chronic pain condition that disrupts sleep, causes depression, and can last years. You, as a patient, can prevent that with just 2 shots. This messaging is not intended to intimidate or threaten the patient, but to give them the facts about the virus and how they can act on it. I would say that my next strategy is to let them know that, hey, you already have the virus. This is the most powerful reframe for those low urgency patients, like I'll get to it or I'm not worried about it. Shingles is caused by that reactivation of the varicella zoster or chickenpox virus. About 1 in 3 adults in the US are going to develop shingles in their lifetime, with the highest prevalence being in those that are 50 years old or older. And so we can tell patients, look, you've had chickenpox. The virus is already in you. It's not a question of exposure like many viruses. It's a question of whether it's going to reactivate or not. And there's a high likelihood that it may. After 50, your immune system's ability to keep it dormant even declines. So the vaccine recharges that defense. And that's why we encourage you to get it. Next, I think a proactive nudge at the point of care. I see this at least in my exposure as a patient myself. I work in specialty clinics, but still we ask this. Testing weather messages, encouraging patients to ask about a shingles vaccine at an upcoming appointment will increase vaccination rates. It's now being studied. But the evidence to this point strongly supports that proactive prompting from nurses before or during a visit actually increases uptake. In other words, we don't wait for the patient to ask for the vaccine. We build it into the workflow. The medical assistant or patient or nurse is rooming the patient for a routine visit, and we ask, "Hey, are you up to date on your shingles vaccine?" That could prompt them to ask what a shingles vaccine is or why is it important to me. And this should really be the standard for those that are 50 and older.
Wow, yes, those are great ways to frame it up for our patients. Thanks for that. Now,
Sure.
one more kind of follow-up question to that. How can clinicians better integrate shingles prevention into broader conversations about aging, chronic disease, and quality of life in general?
Yeah, thanks for that question. You know this as a primary care physician yourself, that we need to anchor it in what they're already managing. A lot of our folks have chronic diseases that they're already managing, and so we're gonna embed it in that discussion. The shingles vaccine coverage in 2021 was only covered about 33% of adults 50 and older, and that's just not good enough. In fact, it was significantly lower in Black and Hispanic adult population compared to the non-Hispanic white adult population. And that's a failure. So under vaccination often isn't just refusal. It's not the patient saying, yeah, I don't want that. It's just that nobody made it urgent. Nobody communicated that urgency to the patient. So connecting it to comorbidities that patients already take seriously is critical. If your patient's managing diabetes, which nearly every adult takes seriously, they either don't want it or they want it to be better controlled, or linking it to immunosuppression if they're in that situation, or heart disease. If we can link it to those things and say, you're at higher risk for shingles because of these, or shingles could be even more detrimental to you should it reactivate, it elevates and really drives home those consequences. So I use that and I connect those. Next, I would say make it a strong, explicit recommendation. Again, I respect patient autonomy, but a lot of times patients are looking to us as the experts to make that recommendation. Don't hedge. Don't say you might want to think about or you might consider. I would say one of the most effective strategies is simply to make a strong, clear recommendation. Encouraging vaccine uptake for patients with cardiovascular disease is as important as encouraging them to take their medications, because patients trust their clinical team, and that direct ask often works. Of course, we recognize again their autonomy, but we also have a responsibility to educate patients and ensure that they understand the benefits and risks of action or lack of action. Timing's everything. So because the patient may not be ready at that moment or at that visit, it doesn't mean we stop asking. It's like smoking cessation. We have to ask them every single time if they're ready to think about stopping. We want to ask them every time, let's talk about that shingles vaccine. So really, my talking brings us right to our end of time. So I want to thank Dr. Huang and Dr. Vieira for their time with us. Our panelists have been outstanding throughout this series. I want to thank the American Heart Association and GSK for making this series possible. This concludes our vodcast series on advancing healthcare professional awareness and understanding of shingles, but the conversation doesn't stop here. We want you to join us for an upcoming live interactive session where our expert panel will highlight key insights and answer your questions in real time. Be sure to visit learn.heart.org to claim your credit, and don't forget, you can revisit and share the full series anytime on major podcast platforms. Let's keep the momentum going and continue working together to improve shingles prevention and patient care.